The concept of FlightBridgeED was sparked when a growing need and a dream united into an idea. That idea grew into a passion, and from passion came a global community of providers and students joining in the revolution of pre-hospital, critical care, and emergency medicine education. Now, from around the world, we are calling our community together. We are proud to announce the FlightBridgeED Air and Surface Transport Symposium in Nashville, Tennessee on March 20th and 21st, 2018. World-class speakers, vendors, and of course, the FlightBridgeED team will be there. Go to our website now to register. Join the revolution. The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today we're going to do a quick podcast, 10-15 minutes, on a topic that we first visited back in the fall of 2016. I've been waiting to get a hold of this paper. It was real hard for me to kind of find, and so I finally talked to my buddy Dave Olvera. He was able to actually text one of the authors, John Sackles, out of the University of Tucson, and he then forwarded me this paper. So this paper was originally published in the Pharmacotherapy Publication Journal in 2016. And the topic that we're talking about is succinylcholine is associated with increased mortality when used for rapid sequence intubation of severely brain injured patients in the ED. Now again, we did this podcast back in late 2016, early 2017. And this was a follow-up podcast to the original podcast we did on succinylcholine when we looked at specifically the study that Dr. Scott Weingart and Dr. Rich Levitan did on passive oxygenation, where they were able to extrapolate and identify that patients that were given succinylcholine over rocuronium had a desaturation time of 2 minutes quicker. And when we look at patients and we compare them from the perspective of our overall delivery of oxygen versus the oxygen consumption, 2 minutes can be a significant amount. And we know the main reason why is because of the mechanism of action of that medication, that it causes a massive depolarization of all those muscle junctions, and that obviously causes O2 consumption to go up. When you compare that to rocuronium being a non-depolarizing neuromuscular blocking agent, we don't have that phenomenon. So that's the hypothesis of why that takes place. So that was a big kind of find. And then when this study came out, obviously this was pretty significant. We know that a huge majority of our trauma patients, level 1 trauma patients, have an associated traumatic brain injury. And we know that when you combine those two, the mortality rate is very, very high. So what they did is they looked at this study, and as I said, I finally got a hold of this paper and I was able to share with you all the different kind of points of the paper and hopefully be able to explain why they saw what they saw. I will publish this in the show notes. If you have never found the show notes, go to our website, www.flightbridgeed.com. Go to the podcast section, find this podcast, go to the very bottom of that podcast, and you'll see an area called show notes. We'll actually publish this as a PDF, and you can download this. I highly recommend, if you're still using succinylcholine as your primary paralytic, I highly recommend sharing these studies with your medical director, because I can tell you that the majority of the HEMS industry, critical care industry, has moved away from having succinylcholine as their primary paralytic. And the majority have said, hey, choose. But I can tell you from my time with Air Methods the last 6 years, rocuronium is the primary paralytic, and so we have to follow the data, and we'll talk about that in more depth. So let's look at the objective of the study. The study was to compare succinylcholine and rocuronium regarding mortality in patients with traumatic brain injury who are intubated in an emergency department. This was actually a retrospective cohort study. It was done in an academic ED in the United States. Adult patients with traumatic brain injuries who underwent rapid sequence intubation in the ED with rocuronium or succinylcholine between the time of October 2010 and October 2014 were included. So when they looked at this specifically, they had to identify patient selection. So a combination of hospital database and electronic medical records were actually utilized for the acquisition of that patient data. Obviously, that 4-year span between October of 2010 and October of 2014. What do they use to measure as far as variables go? Well, one of the things they utilized was something called the Charlson Comorbidity Index. And this is an index that calculates based on pre-specific conditions. And then they also looked at specifically the injury severity score. And this injury severity score ranges from 0 to 75, with a higher value indicating greater overall severity of injury. They also used what's called the abbreviated injury severity for head region, the head region. They abbreviated this as AIS. And that range was from 0 to 6, with a higher value indicating greater injury. The three main variables that they looked at manually, as I said, they were able to extrapolate this data electronically. But when they looked specifically at these 3 data points, they actually had to do this manually. So the 3 data points they looked at were Glasgow Coma Scale, and they wanted to identify the lowest score prior to intubation in the emergency department. They wanted to identify occurrence of hypotension. So they looked specifically at systolic blood pressures less than 90 and an occurrence of hypoxemia with an SpO2 lower than 90%. Now, I find that very interesting. Obviously, the Glasgow Coma Scale we'll come back to, but when we look specifically at traumatic brain injury patients, just one period of hypotension or one period of hypoxia, each of those carry a huge severity increase in overall mortality. And we know that each one of those carries about 50% increase in mortality. So they looked at those specifically, and they had to manually extrapolate that data. Overall results. So they were able to look at 3,258 patients in that time period that had traumatic brain injury, of which 260 were identified as adults who were intubated in the ED. Of these, 25 did not receive neuromuscular blockade, and 2 received VEC for intubation, so they were excluded. So their final kind of sample size was 233 adult patients, traumatic brain injury patients who underwent RSI, again using succinylcholine or rocuronium, and again they just retrospectively looked at these patients. Of these, 149 received succinylcholine and 84 received rock. So here's where we get to the big numbers. And as I said before in different podcasts, when you have a 3, 4, 5% increase or decrease in something in a study, that's pretty significant. But these numbers are just mind-boggling to me. So death occurred in 23% of patients in each group. In patients who received rocuronium, mortality was 22% in a low-severity head injury score and 23% in a high-severity head injury score. So as you can see, there's only a 1% difference. If that patient was considered a low severity versus a high severity, there was only 1%. In patients who received succinylcholine, mortality was 14% in the low severity and 44% in a high severity head injury group. So that is significant. That's a 30% increase over the low severity versus high severity. But obviously that's a massive increase when you look at specifically rocuronium. So what does that mean? When we kind of look at the discussion aspects to this, this was actually the first study to show an association between succinylcholine and an increased mortality in that traumatic brain injury patient when those patients were administered succinylcholine in that RSI setting. We know that this may be related to significant increases in ICP, leading to greater intracranial injury. one of the things that they kind of point out, and again, I really encourage you to read this study, is that the drug companies, the drug administration, actually the initial preclinical data showed a small increase in ICP with succinylcholine administration. But we have to also understand the whole aspects of how does succinylcholine burn through oxygen? Well, it burns through oxygen based on that systemic muscle firing, those fasciculations. And so does that cause an overall drop in O2 to the brain, which causes, obviously, infarction? As far as the ICP goes, one of the things the paper goes into discussing is, it's still not fully understood why there was such a increase in morbidity, mortality, how succinylcholine causes increases in ICP, or if that's agreed upon by all physicians in the field. But obviously the numbers don't lie. So when we look at specifically why do we still see succinylcholine, why succinylcholine is still used in a lot of different instances, especially in the pre-hospital environment. Well, we know historically succinylcholine was, the neuromuscular blocking agent of choice. It gives you that excellent intubating condition. It gives you a very short half-life, and so the pizzazz of that medication was good. It seemed like, we're going to give the EMS providers a medication that they can facilitate intubation, paralyze these patients, but the half-life is short. Now, one of the things when you look at, the comparison between succinylcholine and rock, the superiority of succinylcholine is not there. It truly is not there. And when you compare that to rocuronium, and rocuronium is administered correctly. So what do I mean by that? Well, rocuronium, and I've said this on other podcasts, if you're using rocuronium in an adult population patient, you should always be giving a dose greater than 1 milligram per kilo, or at 1 milligram per kilo or greater, I should say. And the reason why is that our adult population, it needs that higher dose. And so when they looked at specifically rocuronium administration compared to succinylcholine, when that dose was approximately 1.2 milligrams per kilo, there was no difference in overall success between succ and rock and the overall intubation process. So the success rate was exactly the same. So this finding is supported by a review comparing succinylcholine and rocuronium. So the choice of neuromuscular blocking agent in the ED setting should not be based on the likelihood of intubation success, because both agents are equally effective. And then when you get into the whole aspect of, well, we'll just let that medication wear off. And I was taught that initially back in the late 90s when I started RSIing. We know that we're not going to do that. We need to put a definitive airway. And if you fail to place that ET tube, we're going to definitely move to a backup airway, whether that's an LMA, whether that's a iGel or a King airway, something like that. We're never just going to let it wear off and bag our patients. I mean, that's just unrealistic. So we got to get rid of that mindset. Whether you're using rock, VEC, Nimbex, or succinylcholine, you're always going to do the same things. You're always going to prepare the same way. You're going to use your default airway kind of mindset. You're going to assess using the Heaven criteria. You're going to go through your checklist. I mean, I could go on and on. Everything is going to be exactly the same. There's no differences. So we have to look at this from the perspective of what medication is going to give your patients the best opportunity to survive. And we know that our patients, whether we get them to a trauma center alive or in arrest, there's so many variables that go into, do they ultimately survive to discharge? I mean, I think we could agree with that. But that's not for us to decide. And I think that's where you have to make the best clinical decision based on the evidence. And I think when you get into the critical care environment, the majority of these companies' protocols are more like guidelines. And I can tell you, Air Methods are guidelines. They're very open to interpretation. Yes, there's kind of different pathways to go down, but they make you critically think, and they give you the option to choose a paralytic, give you an option to choose a pain management route or medication, etc. We know that succinylcholine carries many, many relative contraindications. I shouldn't have to list those. When we compare rocuronium to that, rocuronium, the one negative of rocuronium, and one study actually showed this, and I've talked about this as well, is patients who were intubated in this study, they had a greater delay in receiving sedatives after intubation because of the appearance of that patient being just flaccid, not moving, right? They had an appearance of sedation. I've found myself in that same kind of mindset where you program yourself for years and years and years to, intubate with an induction agent, give your succinylcholine, and within 5 minutes, right, you're probably loading your patient in the ambulance. The patient starts moving and it triggers you to have that sedation medication, that pain management medication ready to go. But now that we're giving a paralytic like rock at a dose greater than 1 milligram per kilo, we know that the half-life can be up to 45 minutes. The higher the dose, the longer the half-life. So we have to kind of understand that we get busy. These patients are very critical. It's very easy to miss that. So I think that's the one negative. And we know that the intubation process, being on a mechanical ventilator, having a plastic tube down your throat is highly painful, brings along a lot of anxiety. And we have to always make sure that we give these patients the proper pain management and sedation. So I think it's important to, they're talking about in the study to assign additional staff if this is a hospital setting to that patient, just to make sure that they're getting the proper amount of sedation, proper amount of pain management. When we continue, in patients with traumatic brain injury, the possibility of a transient issue in ICP due to succinylcholine does not make it an ideal agent. However, succinylcholine's short duration of action enables post-intubation clinical assessment of neurological function. I think we've all been taught this. We've all been hounded on this, and I'm sure we've all brought a patient into a level 1 trauma center with a traumatic brain injury. They've been given a long-acting paralytic, and the neurosurgeon is upset. But I can tell you, listening to other podcasts, other physicians, there's really no... usually there's no delay. It based on kind of the preliminary things I've heard, when you look at the overall time it takes for that neurosurgeon to come down to that bedside, I'm not saying this is always the case, but usually it's not going to delay any type of neural treatment. And I think ultimately we have to think about, is this patient gonna change based on not getting assessed by that neurosurgeon if they wait an extra 10 minutes? I mean, they still can CT their head. They can still go through those studies and then make an assessment neurologically. So obviously, conversely, rocuronium has no known effect on ICP, but it has a longer duration of action, as I said, based on the dosing. If you're giving that 0.6 milligrams per kilo, that's where you're probably going to have a 20-minute half-life. If you're giving greater than 1 up to 1.2, that's where you're going to probably hit that 45-minute point. So as previously mentioned, this caused a sustained neuromuscular blockade post-intubation, and this could interfere with neurological assessment. But again, you got to look at the long-term effects. We don't want a patient to be hypoxic. We don't want a patient to be hypotensive. We definitely don't want a patient to have increases in ICP just secondary to a medication. So if you remember how they kind of classified and they looked manually at certain data points, Glasgow Coma Scale was one of those points that they had to manually extrapolate. And one of the things they point out here is that Glasgow's Coma Scale did not correlate with that head injury assessment. Remember, that's that AIS. It was unable to predict which patients would benefit from avoidance of succinylcholine. So obviously this question was brought up, and I think it's a great question to kind of talk about is, well, could we hold off and not give succinylcholine in patients that we feel are severe as far as their injuries go? And they're very good to point out that, for instance, more than 20% of patients with the high Glasgow Coma Scale between 12 and 15, suggesting mild injury, were ultimately found to have severe or critical head injuries. So I think that's pretty amazing. That's a pretty powerful statement. This makes it difficult for clinicians to use Glasgow Coma Scale as an assessment tool to determine which paralytic to utilize. One alternative is to avoid succinylcholine for intubations in all patients with traumatic brain injuries, regardless of Glasgow Coma Scale. In these circumstances, even if patients were finally determined to have a less than severe head injury, it would not lead to harm. So that's where you have to come back to. We have to change with the evidence. We have to change with the training, all the constant data that's being looked at and analyzed constantly, and what causes our patients to actually decline clinically, hemodynamically, arrest, have airway catastrophes, I should say. A lot of times it's our inability or our poor planning on the resuscitation side, and that's where we have to come back to remember the Heaven criteria, identify those core points that are going to kill our patients if we don't correct or try to foresee and, again, be proactive in our care. In conclusion, succinylcholine use for RSI in patients with severe traumatic brain injury was associated with increased mortality. It may not be possible to discriminate reliably which patients are likely to benefit from avoidance of succinylcholine at the time of intubation in the emergency department. And I definitely feel like we can translate that to the pre-hospital environment as well. They also identify, guys, that it's really difficult to do a randomized controlled trial with these different paralytics. So hopefully this kind of strengthens what I've talked about before with regards to succinylcholine. Obviously, in some settings, succinylcholine may be just fine, but I think there's a better paralytic out there, and I think the best paralytic out there that we can utilize is rocuronium. And, again, educate yourself. Read this study. If you have any questions, you want to discuss this further, please email me at eric.bauer@FlightBridgeED.com. I'll be more than happy to put you in touch with Dave Olvera or try to get you in touch with the author, John Sackles, or one of the authors. Again, if you came to one of our review classes or, purchased any of our materials, I just want to thank you for the support, for, believing in us. And we just hope that 2018 is going to be just as rewarding as 2017. We hope to meet you if we haven't. Please check out our website. We've got dates listed right now all the way through end of 2018, I should say. If you're planning on coming to Fast 18, guys, I can't stress it. We have a list of world-class speakers. It really is going to be one of the top conferences in the country, and we really hope to see you there. So check out that, and tickets are going to be on sale continuously until February 1st, so hope to meet you in the next few months. If you have any questions, again, email me, and until next time, I'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.